don't know if there's any PVFD music. Go Bob Dylan. If anybody has any requests, let me know. All right, we're going to fade out on Bob. And I know folks are signing in as we go. I just want to thank everyone for joining us. I'm going to have a nice slow rollout. I realize folks signed in right on time, and I appreciate that. My name is Al Marati here from the University of Washington, here in sunny Seattle today. It's a beautiful early fall day. And it's my pleasure to assemble this crew of really nice folks who are very passionate about this topic of paradoxical full motion disorder. And yes, actually one of the topics is what should we call this problem? So we're going to get to that. We have tons of people signed in and they're coming in all the time. So I want to take a minute to thank the Fall Voice Conference for setting up and running these webinars. As you may know, that next, in a few weeks, the Fall Voice program, the conference, which has once again broke registration records over year, will be in DC on Thursday, October 12th through Saturday, October 14th. And it's going to be super. There's this speech pathology pre-conference, there's a Fellows Day, all sorts of good stuff, early career laryngology, then the 2-day actual conference with terrific keynote speakers. I think Joe Stemple and Nikki Johnston are our keynote speakers. I hope I have that right. And it's going to be super. So we are happy to be part of the whole extended Fall Voice experience. And thank you again to the Laryngology Education Foundation for making this possible. I'd like to introduce my speakers today and our panelists. And it's going to be pretty interactive, mostly a bunch of folks talking and discussing, you know, this interesting problem. So as I said, my name is Al Marati. I'm here from the University of Washington. Laura Maturka is a physician laryngologist at The Ohio State University. Laura, are you there?
I'm here.
Right on. And many of you, of course, know Mary Sandage, my colleague, former fellow Wisconsin resident, faculty down at Auburn University, one of our leading speech pathologists.
Thank you. Hi.
Right on, Mary. Thank you. And my just going down the list, I just typed these in some order. I have a terrific partner here that I don't know a lot of you know of yet, but you certainly will. Adriana Schembel just is finishing her PhD at Pittsburgh and is now affiliated, I believe, with the Mass Eye and Ear, and has some really cool information to share about paradoxical fold dysfunction. And so we welcome Adriana to the Fall Voice webinar series. Adriana, are you there?
I'm here. Good evening, everyone.
Right on. Right on. Well done. And then my colleague and friend, Milan Amin, preeminent laryngologist at NYU there in New York City. Milan, looking good as usual. I'm sure you're there somewhere.
Thank you. I'm here.
Right on. And then my partner, Emily Malik, is a speech pathologist, one of our terrific group of speech pathologists here at the University of Washington. Will be fielding your questions. So when you have questions, go ahead and type them into the question portal, and Emily will sort of organize, field, and choose some of the more cogent and poignant. I mean, poignant, that's a little heavy, but the best questions that she thinks will be they'll represent the questions coming in. So, without further ado, anyone have any questions? Right on. Let's get started. Paradoxical vocal motion disorder. You know, also paradoxical vocal dysfunction. Some of us call it. I would not say that this definition is perfect, but this is where I'd like to start. And one of the things we're going to talk about is how do we define it. I define PVFD as the obstruction of the laryngeal airway resulting from inappropriate closure of the glottis during inspiration. This happens often in this bimodal distribution. We see this in young athletes, predominantly female. And then there's a group in their 30s and 40s that is a little more mixed in terms of gender. They classically, not maybe the most extreme, but can have difficulty, inability with phonation during these events. But predominantly, it's an airway issue. Where it fits on the spectrum, everything from throat clearing, cough, including PVFD, episodic laryngospasm, and then this wonderful, useful rubric of irritable larynx syndrome. That's something I think we can talk about. It is historically it's been under-recognized. This paper is now 13, 14 years old. Neil and Patel and I wrote about this in a small cohort of patients, 30 or 40 patients. The mean time to diagnosis was 4.5 years. That's pretty striking. I bet it's better than that now, but it's still not that it's not picked up or diagnosed early, I would say, to this date. So I'm just going to briefly list the things I'm hoping to cover, and then we'll talk about a case, and I'm going to get the panel right in on this. And everybody is free to just chime in. I really want to hear from a lot of different voices. And it's terrific. This is a great example of interested laryngologists and speech pathologists having very helpful, complementary, sometimes differing views on this, challenging problem. We'll talk about nomenclature a bit, clinical fundamentals, diagnosis and treatment. What do we do when therapy isn't effective? What's the underlying cause of this problem? Why does this disorder have such a dramatic female preponderance? And is there anything beyond traditional therapy? Are there things like Botox and surgery? When is that even the right thing to do? So are everyone ready to go?
Yes.
Yes.
Right on. So I picked this patient. It's kind of an old video, but it was such an interesting case that in terms of its clinical presentation. On its surface, pretty standard. This is a 15-year-old cross-country runner. It was female, who began to have noisy breathing and chest tightness with running. It would happen predominantly in competition, not as much in practice, but predominantly in competition. I want to turn that over to the panel. Tell me what are some of the more useful clinical questions you might ask next to help you get to the diagnosis.
Well, when I interview, I'm typically trying to get an idea of the nature of the problem without asking leading questions. So I'd ask them to describe the breathing problem in detail. And if they weren't getting at what I thought we needed, I would ask if they have trouble inhaling or exhaling or both, where they feel the tightness. And with athletes, I want to know if there's a pattern to it. A lot of athletes that I've treated, they have a specific time during the race or the swim or what have you when it usually starts.
Okay. What about leading on to that? What about indoor, outdoor? Do you have people who have more trouble indoor or outdoor or vice versa? Is that ever helpful to you, Mary?
That's helpful for me to help try to figure out what their probable irritant is. I frankly see more swimmers than any other kind of athlete, although I've seen athletes from everything except probably hockey.
Interesting.
Yeah, and both indoor and outdoor. I've seen a lot of rowers, a lot of runners.
Okay. Adriana, what about you? Tell me what's interesting to you from a historical standpoint. What helps you understand the problem?
I also try to start broad and work my way in, and depending on how they answer questions. So, for example, I will ask, do they have any issues with inside or outdoor breathing? And that makes me think of questions like, are there environmental irritants or weather changes or other things that can affect the breathing issue in addition to the exercise itself?
And not to make this sound like this is a doctor question and the other ones weren't, but just since we're going to hear from the physicians, Laura or Millen, what about this chest tightness? I mean, we hear that from these people, from these patients. They often tell us about chest tightness. Millen, what do you do with that information? Does that help you? Tell me more.
Well, I mean, clearly you can see that as a part of this particular disorder that we're talking about. But obviously, when you're thinking about history, especially in a younger person, you want to make sure they don't have any lung pathology. And so you're really interested in looking at whether or not they have a history of asthma, whether or not they have any kind of symptoms that may go along with the diagnosis of asthma. Not to say that those are mutually exclusive, but it's important to understand that issue and whether the chest tightness has something to do with that rather than the upper airway issues.
This asthma question obviously is an important one. I think we're going to circle back when we talk about what do we do when patients aren't getting better. How often do we miss it? Because I think it's hard to tease them apart. There's definitely a chunk of folks who have both problems. Laura, what would you like to add to this? About the chest tightness or about the history in general? All right. Millen, what about you? Anything you want to add about, or Laura, are you back?
Sorry, yeah.
Okay.
I think a lot of us are so eager to help these patients that in patients who have known pulmonary issues, we'll go ahead and take them on and do therapy with them. And I think that sometimes we need to be better about saying, you know what, chest tightness doesn't actually really fit with PVFD. Unless there's been a full workup and you can say it's not cardiac or pulmonary. And that too, I think, this is just a little tangent, but I think that's why it's so important to have good SLPs who will come back to you. They've spent a lot more time with the patients after doing a couple therapy visits. And they'll come back to you and say, I think this is pulmonary. And I know they were sent by pulmonary, but, you know, and we'll go do a chest CT or a walk test and we'll find something. So I think you have to be willing to pass it back.
You can't just, even though we see chest tightness as a, you know, not infrequent symptom or complaint from these folks, we can't just chalk it up to being part of PVFD automatically.
Can I also add?
Yeah.
I just
I
want
do
to add
see it. I see it all the time. But yes, ma'am.
One of the challenges we have with athletes in general is a lot of the pulmonary tests that they do are really normed on non-athletes. So I don't know that we're actually stressing them in the way that we should. For example, even with cardiac assessment, I had a swimmer, they were trying to do a stress test with her on a bike and then a treadmill, and she's not that sort of athlete. She's a swimmer, and so they couldn't trigger the events with those two types of exercise. Therefore, the pulmonary ruled it out, but it was triggered when she was swimming. So I think
let's get then, so these, we've touched on a bunch of the really key nuanced points. Getting back to the fundamentals for a minute. So here we are, we have inspiratory dyspnea, inspiratory noise. You know, I mean, when people say they have expiratory noise, that doesn't tell me that they don't have PVFD. It just means that they may have some expiratory noise. But it's important to find inspiratory noise. Sometimes when they say, no, it's definitely not on the way in, I think to myself, it's probably on the way in, you know, depending on the history. We have to look, of course, but for that kind of history. But so here we are with this situation. Tell me, Milan, medically, what else do you want to know about this patient? So they have these events. They've been severe enough to stop their action, be it practice or a race. They haven't been intubated. They haven't been hospitalized. They may or may not have gone to the ER. You know, what else is it you want to know about them?
Well, I mean, you obviously want to get a general medical history. If there's any other, you know, systemic disorders that they have that could impact their,
pretty healthy.
You know, cardiac. No, I'm saying in this case, but in general, you want to make sure the cardiac status is reasonable.
Okay.
Obviously, we have there are athletes with idiopathic hypertrophic issues with their heart, and you know, you find these athletes who sort of drop dead on the basketball court every once in a while, right? And so, I mean, there are cardiac issues that will play a role in some of these things, but I mean, that's a pretty rare event, right? So, but you want to rule all of that out before you really start to focus on something like this.
Okay, so so here we have this patient. The story is pretty good. Any other non-cardiac, non-pulmonary history?
Triggers. You need to know what triggers it.
Yeah.
Okay, like tell me what? Tell me more, Laura.
Well, either for desensitization during therapy.
No, just the history. So you're saying you need to know this history to do the right therapy? But what about to make the diagnosis?
But then as a next step to treat it properly.
Well, let's stick to the diagnosis. So tell me, what is it that you want to ask the patient the first time you see them that helps you understand that they do or don't have this disease?
So if I hear someone is triggered by strong odors, perfumes, or cigarette smoke, and they tell me that with exertion, they have really rapid onset, and they also recover really rapidly. That's what I want. I want to know throat tightness, how fast on and off, and I want to know triggers. And if that's all I could know, that would help me. Okay.
And Adriana, anything about reflux type symptoms that are interesting to you historically?
Definitely something I would ask. Could be something that could contribute to the history of running, especially runners can, things are slushing around. They can have reflux in addition to their chest tightness and the other symptoms that can contribute. So definitely something that I would ask as additional information.
Is it fair to say for most patients with this story, 15-year-old, otherwise healthy, you don't have a real clue that it's a cardiac thing, they have a bit of chest tightness, the vast majority of these patients are going to be pretty review systems negative. Is that fair? Be candid. I mean, tell me
medical history.
What's not right about that?
Not review systems negative.
Okay. So what's going to be positive? What are we going to pick up on this patient?
I would probably ask more questions about if there are specific places outdoors that trigger it to try to get at allergens. Is it more likely in the fall when ragweed's out, or is it due to chemicals on the grass if they're running at a golf course, for example? Because I think there's
some virulent strain of ragweed or something causing a problem. Okay.
Yeah.
Okay.
I think other thing that we sometimes will, try to gather on this patient is whether they have a history of anxiety or any other psychiatric disorders, things like that.
How common do you think that is? I mean, that's a loaded question.
Well, I don't think the psychiatric issue in general is very common. I do think a lot of these folks have anxiety issues, not so much in general, but oftentimes performance anxiety issues.
Interesting.
Yeah.
Interesting. As my mentor, Bob Toole, used to say, if people can't breathe, they will get anxious, and it's sometimes hard to tell sometimes.
Yeah, it is true.
Here's a real loaded question. So, when we talk to our colleagues in sports medicine, pulmonary, pediatric allergy, asthma, that sort of thing, they want to know why we need to scope the patients. Do you feel, let's just go down the list, Dr. Amin, Mary, Laura, I want to say Dr. Shamble. I know I don't quite have you're finished with your dissertation or everything yet, but let's just go down the list. Tell me, do we need to perform laryngeal endoscopy on these patients?
Yeah, no, I think we absolutely have to. We have to know not only just to look at the larynx and look at the quote unquote paradoxical movements that we're looking for, but we need to rule out other pathology.
Okay, Mary?
Absolutely. I mean, there's so many conditions that could cause that symptom that don't affect voice, like paralysis, mass, papilloma. I mean, there's a host of things, and I don't feel confident moving forward unless the larynx has been cleared.
But many of our speech pathology colleagues are, well, maybe I'm wrong. I imagine that some of them are sent patients saying, we think this is PVFD. We haven't looked. Don't you think some of your colleagues end up having to treat patients without looking at the larynx? And is that good enough? What do? Do they say, stop, I'm not going to do this until I see the larynx?
Well, they at least need to see the otolaryngologist to have the larynx cleared pathology.
Okay.
The other issue is with this population is that superior glottal collapse that can occur with exertion, and that has to be ruled out as well.
Okay. All
Which
right.
I don't really think is PVFD. I think it's
let's stick to the
an obstructive
main
condition that's different. Yeah.
Yeah. Let's stick to the heart of it. The variants and nuances are important. The related nuances. Let's stick to the core stuff. So Laura or Adriana, anyone want to comment on that?
So I definitely agree with Mary and Millen that at baseline you have to do a laryngoscopy at rest. I also think that advocate for laryngoscopy with simultaneous trigger provocation can give us lots of really good information. And actually, you mentioned that I'm working on my dissertation, and I just finished with analysis. And some of the interesting findings that I found in my work with athletes with PBFM was that when raters were blinded to the condition and to the group, because I had patients, I was looking at patients with PBFM and healthy controls, raters with lots of experience couldn't tell a difference. So yes, ruling out other organic or anatomical pathologies is super important, but to increase sensitivity of diagnostic testing, I highly advocate for provocation challenge with laryngoscopy as well.
I know Emily. I don't know if you just texted me, but one of our questions just came in, which is what I was wondering myself. So one of our attendees, an anonymous attendee is the name of this person. What if laryngoscopy is performed but no paradoxical full motion was observed?
See, I do disagree with Adriana in that I don't think I have to see it to treat it. And honestly, in the clinic I work in, I'm reluctant to provoke an event because for several reasons. One, if someone doesn't have previous experience with overcoming an event, I might have trouble talking them out of it, which would lead to them thinking I didn't know what I was doing. I think they would lose some confidence in me. Yeah.
Okay.
So with that, what we typically do in Mass Pioneer is we do all the education. We go on the assumption that they have PVFM, and then we do all the education, psychotherapeutic counseling. We talk to them about rescue breathing. We teach them rescue breathing techniques. We talk to them about control postures to prevent the provocation from happening. And then we use the exam, the provocation challenge, as biofeedback and to show them that they are in control of the attack and they can get
now that's
out
at the
of it.
initial clinical interaction. Okay.
So before you've scoped, you go through
Before,
it.
yes.
Okay.
And we say if it's not, if we try to provoke you and we don't see anything, well, you just learn something extra for fun. But if it is, then
so you're saying
they can go right into it.
So that's your you're saying this to help describe the situation that Mary expressed concern about. You know, you don't want to. We don't want one of our colleagues to find themselves provoking and not being able to either manage it, be it medically or affect the therapeutic relationship by that. You're saying your way around that is to go ahead and preload these people with all these options, and then and only then even do their fundamental initial laryngoscopy.
Correct.
Okay. I must say, I don't know that we're casual about it, but we don't do that. I've got to say, we do the exam, and then, as you said, use the biofeedback. I would say it's hard to argue with this for most folks who do take care of a lot of this, but boy, the biggest magic, I mean, yes, it's nice to look at the larynx and make sure they don't have anything bad, but biggest magic is when they see just what the heck their throat is and does and how it works, and it just makes such a difference in terms of their capacity, our capacity to explain and have them understand what the heck is going on and how they can be in control of it. And that's a dance we have to dance, you know, to describe a disorder which may have behavioral intervention as its mainstay of treatment, but is not necessarily at its heart a behavioral problem. Mm-hmm. How's that for a loaded?
Love that.
Mm-hmm.
Okay, e-hug. All right, everybody out there, all the attendees, good. I'm sure you grab someone near you. All right, so we believe in laryngoscopy, and we heard a little bit about, yes, please. Yes, Emily, hit me.
Along the diagnosis
yes.
question, how do you provoke PVFM during laryngoscopy or your evaluation?
Great idea. So practical. So we heard that Adriana, pre-preps them, but let's say, however, they got prepped or not prepped. How is it that you provoke? So Adriana talked about exercise. Laura or Mary, in the situations where you've done it, Millen, how do you provoke these folks?
I mean, this is where we have just a standard, we do this on every single exam. We have them breath hold, then we have them count to 10 on one breath, and we have them count as high as they can on one breath, or hold out a knee. And then if that doesn't work, then you move on to odor triggers, or you take the scope out, exert them, quick pass it again. Or if you're in Denver, you do it while they're exerting.
Okay. So yeah, we found, we started doing rapid counting years ago. In fact, we call it positive rapid counting. And I don't know what it means other than it helps me show them what's going on, right? If somebody's got a great story and they don't have inappropriate closure during rapid counting, I don't think it means they don't have the problem, but when they do it, it helps me explain it to them. Do you think that's fair?
Can I ask the group, if, let's say that what they describe is paradoxical, but you're not able to trigger it in the clinic, do you then rule it out, or does it still remain a possibility?
It depends on the history.
Yeah.
Yes.
Right. That's a great question. I mean, I don't know, Millen, what do you think? I mean, do you think?
So we generally, what I do is I categorize people as probable and definite. And I think if I get a really strong history, but I don't see it, they're probables. And we will go along the treatment pathway knowing that we don't have definite confirmation. If they're definites, then we go a little bit more aggressively down that pathway. And that's how I just think about it in my head.
I have a question for Adriana, and only because you've done a little more specific recent research on this, and forgive me if anyone else wants to chime in as well. So let's say you provoke them in some manner, right? Chemically, rapid counting, exercise. Does the presence of aberrant closure during provocation predict a better response to therapy or not? Right? Story's good, but you don't see it. Those people are they less likely to respond to therapy versus story's good and you do see it? See what I mean?
I don't know if we can answer that question right now. I think that we should be doing therapy for both, and treating it like diagnostic therapy. So if they do improve, then we can say, oh, we didn't see it, but they did improve. So there's a probability that it is PVFM. And if I see glottal constriction with provocation, then, but I know for sure. Then I feel more confident.
Okay, so that's an excellent PhD answer, which is what we need. Let me go back to do you think patients you see it, do you think they're more likely to respond to therapy?
I think so. Anecdotally, as a therapist, yes.
Yes. Appreciate your confessional tone, by the way. Anybody else?
There is evidence that addresses this.
You got me beat. I didn't know that.
Well, a paper looking at, of course, out of Ohio State, looking at irritant-induced PVFD, it did show higher rates of response when there was an irritant, that when there was a clear trigger identified. And I think
historically or on examination?
When they, well, both historically, and then if they didn't have spontaneous.
That's cool. I didn't know that.
Yeah, and the authors said, you know, if there's an irritant, then you can do desensitization in therapy. You have more therapeutic tools, and so for that reason, I agree. I totally agree with Adriana.
Okay, unless anybody has something particularly zippy to say, I'm going to move along. We got a bunch of questions. Emily, that was a great one. So here's laryngoscopy. This one was a little interesting only because she was in status paradoxica. She, just during the examination, this is at rest, admittedly during the exam, I should say. I'm not trying to provoke her. She's just locked into this. That's inhalation.
That's really tight.
Okay. Yes, and this is now, admittedly, getting light nasal spray and having a scope in is some form of provocation, right? We have the observer effect here. I admit that. And then the one and only, this is back, such a great video. I kept this an old one, but you can hear Carol Toliano. Carol, if you're out there, thank you. Just talking her through this. The patient was scared, right? It was happening.
And have your tongue still forward in your mouth, just laying there like a puddle of water. Your jaw's going to be dropped. Jaws dropped just like that. Now just close your lips.
And just, you know, doing like many of us have seen our terrific therapy colleagues do, just kind of help break that moment. So before we go to the specifics, I would like to hear, particularly from the therapist, what are some of the pearls of therapy? Let me ask, before we leave the clinic room, the diagnostic room, we agree that looking matters. We agree that having the patient see matters, not just us looking, them seeing it matters. What are some other clinical pearls or nuances of the history examination? One of that I was taught to, I think, I can't remember if it was Carrie Toliano or Carrie Marisol, one of my partners back in Milwaukee, who described the tracksuit sign, right? If either one of the parents is wearing a tracksuit during the clinic visit, it's very highly likely they have PVFD. That's a positive tracksuit sign. So thank you to my Milwaukee friends. I can't remember who it was, so please remind me if it was you. But any just couple clinical pearls, history and evaluation before we get on therapy. Anyone want to chime in with one?
I think that improvement with inhalers can give us good information. So if they have their symptoms improve vastly with inhalers, then especially for differentially diagnosing asthma versus PVFM, it's good information.
Okay.
So if they improve drastically, then we're thinking more along the lines of asthma, not to say that PVFM doesn't also play a role, but if they come in, they say, I've been using my inhaler, I'm really compliant with it, and there's no difference, then we're thinking, okay,
that's a good fundamental.
Probably not asthma, it's probably PVFM.
Well, I do think there's a caveat to that. I spent a lot of time describing what asthma is, primarily trouble exhaling versus a PVFM or PVFD presentation. And then I asked them, and I learned this from Mary Schroth, pediatric pulmonologist at University of Wisconsin, because people would say, oh yeah, my inhaler works. And she would ask them, well, how long does it take? They said, oh, it works within a minute. She said, well, then that's not the inhaler.
Interesting.
Right? So I think it's very important to ask, how long does it take before your inhaler works? And if the answer is within a couple minutes, I'm doubtful that it's asthma. I think they're probably relaxing out of some throat tension.
Okay. That is a very good point. So it could be decreased throat tension, could be you're creating a semi-occluded vocal tract when you put your lips around the inhaler, and it can mimic respiratory retraining exercises. It can also, you're doing something, you're in control by taking inhaler, so there can be a psychological component as well. So I agree with Mary on that.
So let's move on to treatment. There's obviously, there's more on this, but
just to interrupt.
Emily, you have a question? Yeah.
Yes, we have two. One is just a quick clarification question. It's, can you explain the provocation technique of tight breath hold and rapid counting?
Okay. And what's the other one, just so we can handle them all?
The other one, we've actually had multiple questions about this. How common is dysfunctional respiration pattern or shallow breathing with PVFM patients? And may this be associated with the symptom of chest tightness?
I would like to handle the other one, and I might be wrong because I'm wrong a lot. I don't know that I have a lot of patients where I can't figure out what the breathing problem is, and I find myself going to shallow breathing patterns. It does happen a little bit, I think, but I don't know that that's a real common overlap in the clinical presentation of most of these patients. And then let's go to the other one in a second. Does anyone disagree with that? Please be candid.
I think it depends. I do see more breathing discoordination with the upper respiratory tract and lower respiratory tract in athletes, where the larynx is acting more like a respiratory conduit. But yeah, I think it depends. Probably less so with
like
the irritant.
5%, it depends like 50%.
Depends on who you typically see in the clinic. I do see a lot more breathing pattern disorders in athletes that come into massive.
I would agree with Adriana. Specifically, a lot of breath holding in swimmers. They're just they're holding their breath while they swim and then explosively exhaling and trying to inhale on the head turn, which is ridiculous. I mean,
this just means I got the right people on the panel. I didn't know that. That's great.
Oh,
That's really
swimmer breathing is this whole mysterious vacuum that you really have to spend time in the assessment understanding specifically what they think they're doing when they breathe and how they're breathing, because often the coach doesn't even know they're doing it.
Our SLPs used to go to the pool. I mean, they go to the Ohio State. Yeah, I totally agree. We see issues.
The nice thing is a lot of the collegiate teams now have camera capabilities, video recording capabilities, so you can ask them to go pro or to use videos. You can see what's happening, even if you can't go to the pool or to
I remember going to the pool at Vanderbilt, the rehab pool with Ed Stone, and watching a swimmer like just come to a dead stop in the middle of the pool it's pretty helpless. It's pretty impressive.
Oh yeah.
I still think for the majority of patients, for folks who aren't in referral centers, maybe I'm wrong, but I don't think it's I think many of the patients we see, the cross-country athletes, the soccer player, volleyball, et cetera, they're mostly going to have more of the traditional glottal closure things. That'd be my guess. In terms of the rapid counting, there was a breath holding, which I don't know the answer to. Rapid counting, we just take a deep breath and just count as high and hard as fast as they can. We just basically try to get them out of breath and just see what happens in the first few breaths when they breathe in. That's about it. Nothing too deep on that.
You're looking at what they do after.
Correct, not during. Excellent point.
Can I ask a question? Has anybody looked at what typical people do after?
No, I don't know if that's been studied.
I'm just curious because I would guess that they might narrow their larynx a little bit for a rapid inhale.
Yeah, but everybody can.
That would be a great master's thesis. Thank you for that.
Excellent. Yeah, I'm happy to be a co-author on that. Middle East.
All of us.
Awesome. That was easy. Okay, moving along. So tell me, let's go down the list. I'm going to start let's start with Mary. Mary, what's your, let's say it's if this is fair to say, a pretty clear case, adolescent athlete with pretty clear paradoxical vocal dysfunction, not a lot of medical complications. Beyond educating them and showing them how the larynx works, how do you treat them? What can you boil it down to a minute? I know it's not a fair question.
Okay, so the fast answer is I actually spend quite a bit of time talking about Eric Kandel's sea slug research and to give them an out that there are probably physiologic reasons why their larynx is more trigger happy when they're around these agents, and that with training they can overcome that. And then I spend time identifying what the triggers are so that they can either avoid it or learn to desensitize to it.
Does there always have to be triggers?
When I'm counseling,
I don't look at it that way.
Useful model. It seems to be a useful model. But then with a runner, often in my experience, they'll say, it always happens around the beginning of the second mile, or it always happens. Yeah. And so I have them start doing the rescue breathing right before they hit that point. Just every time you're out running now, when you are starting to approach the 2 mile mark, just start doing it and do it until you feel the tightness pass and then go back to regular breathing. And that seems to be very effective.
Thank you, Mary. Can I have Adriana pick up on that tell me what, either different or how you like to add to that, to say, what is your basic treatment?
Yeah, there's a lot of parallels of what we do at Mass Eye and Ear. The slight difference that I would highlight is we do something called laryngeal control postures to prevent the symptoms from happening in the first place. And this is a shout out to Kathy Balliff if she's watching. This is her work, where it involves different muscles of the head and neck region, stretching and relaxing. Could be tongue protrusion or retraction to release base of tongue musculature every 3 breaths or 4 breaths or so many breaths to keep everything nice and relaxed and prevent the symptoms from onset of symptoms. And then the traditional Florence Blager rescue breathing is what we do once if they have symptoms and to help them get out of it.
I have something provocative to ask, speaking of a provocative test. When you're dealing, again, we focus a lot on athletes on this, but when you're dealing with these folks, are you allowing them to perform better or just keeping them out of the ER?
Both.
Right?
Both.
Do you think you can, well, I mean, are you making them super functional or are you just keeping them from being limited by this aspect of their performance?
Look, most of the athletes I see are elite athletes. They're going up a level, and if you shave seconds off their time in the pool or running cross country, to become more competitive. So
now let's turn it back out to the broader audience, right? I mean, so let's remember, so standard patient, high school athlete, wonderful that they are, seeing one of our colleagues who may not see the practice you see. What is it that the therapist can reasonably, or the physician reasonably can say, this is what I expect to happen with your therapy with regards to performance?
So I think a baseline, our goal is to retrain and coordinate breathing patterns with the larynx of how the larynx responds. And if it's true standard PVFM, then I think we can keep them out of the ER, we can make them better. It's when there's concomitant other things that are in addition to that, sometimes, especially if they are medical, like asthma or COPD or other kind of medical disorders that aren't treated well or managed well. There's only so much we can do. But if it's purely PVFM, I agree with Mary. I think that
those are both. So both, I don't want to say ends of the spectrum, but those are both important patient subtleties and populations. I have something maybe. Go ahead, Melanie.
I was going to say that one other thing I think that's very important in all of this is that, a lot of these folks will, their biggest concern is that they're going to just flail in the middle of, a meet or whatever it is, and that they want the confidence to be able to know that they can get out of it, that they can work through it. And I think that plays a big role in why they're there too. And I think that relieving that anxiety that goes along with, I'm just all of a sudden just going to fail and just stop in the middle of the pool and start like flailing around. I think that goes a really long way in helping these folks.
Cool. I have something provocative for all of you. And let's start with Laura because everyone else chimed in recently. Why do we expect the larynx to be able to do all this? Why can't it just be the larynx can't do this? We know people can't run 40 miles an hour, right? And we don't say, well, that's their larynx. It's their legs. It's their cardiac output. It's their extraction from the lungs with oxygen. Why can't the larynx be the actual physiological limiting step to athletic performance?
I mean, one question we always ask is, especially in a lot of the younger patients, is a lot of them are doing things they've never done. Are they just learning what it's like to live in a body that changes every year? And, people, I think, talk about this as a marker of hypochondriasis or something like that. I'm not really saying that exactly, but yeah, I mean, I think there are limits, and I agree with Mary in that you can eke out additional function in these elite athletes. But I think that there are a lot of other patients, and maybe the more common ones, where we're just kind of showing them their ceiling. Mm-hmm. And,
interesting. Okay.
And that's why the video is so important, I think.
I've always wondered, is there something about their PCA muscles that they just don't have the same fatigue resistance? We all expect this of these muscles. I mean, I wish I knew this, that there's just a physical limit in some of these patients.
Well, that's exactly right. It could be some of those patients, but the ones who have triggers like specific chemical
Right.
triggers, you wouldn't
Right.
you wouldn't say that that's the case.
And I
But don't
think we're
you
going
think
to
if they
drift
had
to
a
that.
don't you think if they had a predisposition to a weakness that they would probably just not be in those activities that trigger? I think
don't know.
they would opt out of sports because they were hard.
Unknown.
That's what
You're
usually
right. I don't know.
does it. They're
Maybe
hard.
it only shows up at the extremes. I don't, Mary. I don't know. I wish I knew. I think.
I just want to add one other thing. I
Yeah.
think the psychosocial implications of just anybody with this are really important. And for, I don't want to focus on elite athletes, but for high school, active children that get it, I think being able to hang out with their friends is really important. And if they can't go to the pool and swim with their team, if they can't go run with the, at a meet, that's very isolating. And that's also really important.
The profile of these patients, which we can't be lazy and just assume, but we can certainly reflect on it, is that these are often sort of the grinders, right? They're not always the smartest kid in the class, but they're the ones that have a pretty good GPA. They're really driven, competitive. I think we studied this. We looked at like the mean GPA of these folks compared to patients with other breathing disorders. I forget what the study was, but there's something different about, at least again, this teenage folk, the teenage athletes. I want to, one more thing from Laura, please. I'm going to move on. Go ahead, Laura.
I think you have to be careful. I think you have to be careful about that because that was true 20 years ago, that they were type A, and the ones who came to our attention maybe were that. But I don't know if that's as true now. I see a lot more who have bad reflux or who just have a really hypervigilant PCP or pulmonologist. And so I think you have to be careful and make sure they don't have allergies or reflux or something very concrete that you could treat.
Okay, good. That's a good, I think that maybe as our community, we've educated people and we've matured, maybe that is the patient group is changing a bit.
Yes.
And I also think we have to be careful not to overgeneralize anxiety or psychopathology. I know. Because, so not to talk about my work, my research, but it's in the forefront of my brain because I'm working on it right now. I actually used a adolescent temperament battery and compared elite athletes with vocal cord dysfunction or paradoxical vocal motion disorder to those without. And there were no differences in their temperament, in their stress reactivity. But the way that they responded to potential stressful events were significantly different from the general athletic or the adolescent population, the typical adolescent population.
Interesting.
So I think we see anxiety or perfectionism or certain temperaments in these individuals because that's who comes to our clinic. But I think we have to keep in mind that maybe these individuals it's a more of a indicator of who they are as athletes, as individuals, and less with having to do with the diagnosis itself. So just I think it's important to keep that in mind.
Listen, we have about 20 minutes left. So what do we do when therapy isn't effective?
Also, before we move on, we have a couple of questions. How does treatment for PVFM differ between type of athlete? For instance, how would you treat PVFM differently for swimmers versus runners?
Okay. Adriana, you want to try that one?
Yeah. So actually, Mary, I think since you're the one who
please
deals with swimmers, I think you're probably better at answering this.
Well, I think land athletes are in some ways less complicated than the swimmers. You really need to spend a lot more time inquiring about how the swimmer is inhaling and exhaling, because that may be the fix if they're breath holding. And so the other thing with swimmers is they're horizontal, they're breathing against water pressure, and so their respiratory physiology is just different. And I think they're probably more predisposed to allergies because of the environment they're in. And in my experience, they're more predisposed to reflux because of breathing in a horizontal position. I also think with the athletes, you have to ask about what they're eating before they get in the pool, because some of them are loading up on high-fat foods. I mean, you just have to take just an incredible level of detail so that your intervention is very patient-specific. So with the swimmers, I've stopped working with them on land completely, and I just work with them in the water, because if you believe that specificity is important, then, and they don't have trouble breathing on land, then just get them in the pool and have
Emily, what was the other question, Emily?
The other question was, how would that differ from treating other types of athletes like running? But I think we hit upon that.
Okay, let's move on. So just broadly speaking, I'm going to answer this first one. What do we do when therapy isn't effective? And I'll throw it out for comment. You know, I always say, you know, if you've got a pretty clear diagnosis of PVFD and people aren't getting better, right? It's either the wrong diagnosis, maybe seeing somebody who is not either understanding or applying the therapy correctly, or the patient's not doing their part of it. So I think all three of those fairly have to be explored. And it's frustrating because they sometimes, soapbox alert, you know, it's frustrating because sometimes they come in saying, well, I tried reflux medication, I saw a therapist, now what? And, you know, it could be that I talk about this sequencing, right? It could be that they really did have a component of reflux and they really did have a behaviorally improvable speech pathology approach to their breathing, but they really weren't applied in the right sequence or at the right time, and patients will often come in frustrated with both of those therapies, but what they really needed was to have them both sufficient, but each was necessary. That, I would say, is pretty common, and just having that in your verbal sort of discussion with the folks, you know, to help re-engage them, because the last thing, you know, you say therapy and they go, oh, I did that already, you know, and that's hard. Anybody want to comment on that? Is that crazy, out of line, good, bad?
I think that makes really good sense. We try to really try hard never to recommend therapy to someone who we don't actually think will benefit. We don't do therapy just as a, let's try this, because of that, because maybe they actually need therapy in the future and it really would help. They sour on it.
Okay. The other thing I've noticed is it's like the blind man and the elephant. You know, the allergist has treated the allergies. That didn't fix it, so they quit. The gastroenterologist has treated reflux. They try that. It doesn't fix it, so they quit. And I find as a speech-language pathologist, I'm trying to treat, you know, I usually communicate with the physician, can we please give this stuff another try all at the same time with the behavior intervention to just try to get them over it, and then taper the medicines after they're fixed.
Cool. I like that. Yeah, that's kind of a little bit of the sequencing, but I think it's so important if the speech pathologist is engaged with the physician, whether or not there's an otolaryngologist or a laryngologist involved. You know, I think it's really healthy for the patient.
Yeah.
Any other comments on that?
Well, I think you have to specify what therapy means, right? I think that we all see this quite a bit, where they go to a therapist and then they come back and they're not any better. Do you know that they didn't get better because they are not going to respond to therapy, or because of the type of therapy that was done? Or, you know, did they have some type of, you know, feedback that did they get visual feedback? All these things that we really think of as standard of care when our therapists are doing it, are they getting that on the outside?
Right. And that's important, right? Yeah, we have to engage, educate, all this stuff. But, you know, we've got a lot of experienced clinicians listening, so I'm sure they'll figure it out. We talked a little bit about the underlying cause of this problem. We did not touch, you know, we focus a lot on athletes, young folks, at risk of really changing the topic. You know, there is a different group of patients, this adult patient, and more mixed, you know, male and female, who have this irritable larynx. Some of them have reflux as a fundamental trigger. Some of them have some aspect of neurogenic neurogenic injury, neuropathic injury. Tell me a little bit about this. So what do you think about these patients? Let's start with Laura on this one.
I mean, I think I talk about this a lot, but the referral patterns are so important, because it depends so much on where you practice. So, I mean, anyone listening who's about to go out and start a practice somewhere new, the first step is to figure out what your pulmonologists know, what your family practitioners know. And, you know, even between different clinic settings during the week, I approach these patients totally differently. So, yeah, a lot of these older adult patients, I think, come about because we have regions of the country now where awareness is really high. They were always there, most likely.
Right.
A lot of them have COPD, but they feel better when they do the laryngeal control therapy. And part of it's because it overlaps a lot with pulmonary rehab techniques. Interesting.
And Mary or Adriana, you want to comment on that? You know, this different patient population, the adult patient.
Yeah, you know, I think one thing that's important to remember is sometimes, you know, allergies can have an onset at any time of life. And so I'm usually spending a lot of time asking very detailed questions about any environmental changes. I've treated a number of people who've moved into new construction, and that was the trigger because of building materials and that sort of thing. There's stressors that happen as we age, as parents die, and we are taking care of our children and our parents. So I think sometimes we're more vulnerable because we're just stretched so thin. So, and sometimes it's bizarre things. I had an 80-year-old guy that came in who was he was triggered by the polyurethane fumes coming off of his new TV. And I thought he's got some cognitive problems, but as it turned out, it was fumes. So
the TV was speaking to him directly.
It was.
More chemical. And the chemical.
Yeah, I think I see more unusual triggers in the middle-aged population and older than I do in the youngsters.
Interesting. There is, there is something to that. I think the reflux part is important. Many of them have been told reflux, but I think I would say that reflux should be really a positive, that something that by thought and examination, not just as a throwaway. Anyone else? Someone has their speaker on, and I'm getting a little Lombard effect. Even I remember that from school. So just anyway. So jumping back, forgive me, to the adolescent group. Why does this disorder have such a dramatic female preponderance, or at least has had? Maybe Laura is saying that that's changing, but tell me your thoughts. No particular order. Go ahead.
I mean, a thought I have is the same reason why married men live longer. It's because women are more likely to go to the doctor for things. And I think that's part of it.
90 to 10? I mean, it's a big difference.
It's big. It's not 90 to 10 anymore, I don't think. Even nationwide, I don't think so. There's also this idea that there was a paper that showed that it fits with the psychological and stress profile of a conversion disorder in a lot of patients. And so these are patients who...
that was an Ohio State paper as well.
It is, yeah. They may, they may report high stress levels, but they will not report depression. They may not report anxiety, and yet this stress manifests in some way, and they fit this conversion profile. And so I don't want to overemphasize that because I think it's so important to find the reflux and the allergies. But I think you have to think about it, and that's why seeing the video matters, because they look and they go, oh, it's fine.
It's hard, I have this new political job with the Academy, and I was describing, I'm like one wet finger in a room full of light sockets at all time, or I was just trying not to say the wrong thing. It's hard to say, gosh, women, even if it's not 90 to 10 anymore, there's still, I think, a female preponderance in this group, and it's hard to say there's something about them psychologically that's different. I'm not saying it's not true. It's just, it seems too easy. Isn't there something physiological about them? I mean, isn't there something about reflux? We talked about progesterone and athletes and reflux and all that. Is there something about them? Are their airways smaller? Do they not? Does it alter their flow? I mean, I don't know the answer. It's got to be something we just haven't figured out. What do you think?
Al, we talk about this also with voice as well. Why are some women more prone to certain voice disorders than others? Why do they develop? Why do men get hemorrhagic polyps and women get more?
Look at Lucian's work.
Right, exactly. And so I think there is something to an anatomic issue. It has to do with the size and the shape of the larynx. And we know that a lot of the issues, at least I feel, a lot of these issues with these breathing disorders have to do with airflow across the larynx. Obviously, the smaller larynx you have, the more negative pressure you're going to develop at the glottic level. And they may be just more prone to developing this this adduction during inspiration.
I actually think there's some cough literature that indicates women are more prone to cough than men. So it may be that there's something different in chemoreceptors or mechanoreceptors.
Could be too. Yeah.
I think. Good. Yeah, please. Is that Adriana?
Yeah, I think it's important to keep in mind that we have all these theories, and all of them could be possible. It's most likely not one thing or another thing. It's probably, the answer is it depends on the person and the population. There's probably in some cohorts a psychological component with higher prevalence of mood disorders and anxiety disorders. There probably is a cultural influence. So men are taught not to talk about things like that. They're just taught to rub some dirt in it and keep running and do their thing. There's probably a biological or physiological component. So there's a lot of hormonal and developmental changes that happen in adolescence. If we're talking about the adolescent athlete population, so there may be hormonal changes, growing pains.
Sounds like you've got a career of investigation in front of you.
Even
biomechanical, so it could be, so they have smaller airways, high negative inspiratory pressures.
Let's do a couple things. I know I just sort of lit that fuse and it could go on for a while. We have about 5 minutes scheduled left. I do want to get to a real quick rundown of the role of Botox. And then I know Emily's been waiting with a couple questions to pitch in. So we may go a minute or two over, so forgive me. I'd like to hear from both the therapists and the physicians. Who uses Botox for this problem? I know I have.
I have, yeah.
Yeah.
I don't like it.
Pretty rarely, yeah.
Much,
why don't you like it, and how rarely?
Maybe twice.
Yeah.
Ever?
Yeah.
We just looked at it, and between the three of us, I think 7 times, something like that. My partners told me that they've gotten fairly good responses, and I haven't on the ones I've done.
I asked Chuck Ford to do it once on a real refractory teenager who came out of anesthesia and laryngospasm and was sent home and was told all teenagers do this, and it was kind of ridiculous. Anyway, she had a lot of fear, and with counseling, and we just could not get a handle on it. So we did it as a last resort to try to just get her larynx stable. And it was very effective with her, but.
Rare. So, I mean, it's rare. I would say, so I've been doing this for 20 years. I would say the number of patients with a primary diagnosis of PVFD in whom I found Botox, or found myself trying or recommending Botox, I'd say it's between 5 and 10. I have trached 2 people with this as their primary diagnosis in 20 years. I find these patients fascinating and rewarding, and I see a lot of these folks, and I would say 2 is not a big number, but it's bigger than 0 in terms of folks who end up with a tracheotomy because of this problem. Botox I found useful in, I think, both those patients, if I remember correctly, as a bridge towards decannulation. They couldn't get out of the ER, and these patients were getting intravenous Precedex or Propofol or whatever, just to break these things that we just could not break otherwise. Botox wasn't good enough, and they needed some sort of secure airway.
Al, are we going to talk at all about the role of like benzodiazepines at all in this? I mean, we see that a lot.
Tell me what you think about the role of benzodiazepines.
Well, I do think there is a role in some of this population. I mean, we see this a lot. Patients will go to the emergency room and not necessarily get Propofol or Precedex, but they'll get benzodiazepines oftentimes.
You mean
many
in
of them?
Acute? You're talking about
really
not as chronic management.
No, I don't think it's a great chronic management. I do think
I was surprised to hear that. Okay, so you mean acute.
No, but there are patients in a sort of intermittent chronic way that I will recommend that. Like I had a patient today who came in who had PVFM, and she has basically, and this may be an allergy related issue because she has it every fall, but she gets it several times in the fall. And so her doctor had prescribed her Ativan to take intermittently in the fall when she has these episodes. And she was nervous about it, and her doctor was nervous about it. And I said, this is really not a problem. If you're having 3 times in the fall and that's all you have them all year, I'd rather have you take intermittent benzodiazepines than try to be on something chronically or do Botox or do surgery.
Interesting. I hadn't thought of it that way. That's interesting. Because obviously, like every inexperienced patient, doctor with this stuff, I'm always fearful that I'm going to do something wrong. I'm going to be on this drug, or I don't know what I'm doing. So there's so much more to talk about. I want to see if Emily has 1 or 2 particularly zippy questions to throw away. Zippy now.
Describe the role of Heliox during your treatment, and then someone also asked about the potential for nebulized lidocaine.
Well, let's talk about those. Let's go back to Millen for the Heliox, acute, right? Not chronic. We're talking acutely, I presume.
Yeah, I suppose you could use it. I've never really done that. We've obviously done it in patients who have airway stenosis. I imagine that, it would do a very similar type thing and that it would get air through. But there's many other mechanisms to get these patients to break their paradoxical vocal fold dysfunction at that time. I don't know that I would refer to that necessarily.
And interestingly, I bet, and I've seen it once, which means, I base everything on this one experience, but if you popped a blood gas on one of these patients during a profound event, I bet they would be hyperventilating. They're actually moving more air than you think.
Yeah.
So I don't know there's a good role for Heliox. It's not evil or wrong. I just don't know that I'd use it. And
I had one patient doing it as a last resort.
Just
And she couldn't get
in
off
bed?
it, so she ended up being trached. So,
Okay.
Yeah.
I mean, that's a
Alright.
very, very extenuating circumstance. It would not be.
Wait, what's her name? No, I'm kidding.
Yeah.
All right. And what was the other part of that, Emily? Sorry.
Lidocaine.
Nebulized lidocaine.
Nebulized lidocaine. Yeah, tell me about that. Diagnostic. Laura, what do you think?
I have I think maybe 2 people who I've actually set up with home nebs. And they,
Of lidocaine?
yeah, and
Interesting.
these were really severe patients, but it temporized. It kept one out of the ER for a while, and then she kind of broke through that too. She's getting a Nissen now, and I think that's something I do more often in those patients.
Okay. So an anti-reflux operation.
Yes, correct. Yeah, her pH.
Well, we did not. Your pH probe, yeah. Well, we did not get to reflux. When I get to the vagal neuropathy part of it, I do want to respect everyone's time. We're right at an hour. I know people are probably tapping out and turning on Game of Thrones or whatever it is people do on Tuesdays. But real quick, I'm going to ask the following question of each of you. I'm going to ask, if you could know one thing about this disorder and just have this revealed to you by the universe, what would you know to help understand the disease better? Mary?
I guess I'd want to know, like, where exactly is the tipping point from not being irritated to being irritated? Because,
Okay.
I mean, what is that amount that's the tipping point for these folks?
Millen?
I think I'd want to know, is this all one disorder or multiple disorders? I really think that we don't understand it, partly because I don't think we even understand what the scope of the issue is.
Okay. And Adriana?
To piggyback of what Millen said, I would love to know the cause, the underlying mechanism, the driving either one disorder or multiple disorders.
Okay. And what about you, Laura?
I don't even know where to start. I guess I'd want to know how to, I think it is clearly multiple things. I want to know how to figure that out, short of pH probing, allergy testing, doing nerve blocks on everyone.
In that big China cabinet of medical answers, I'm sure there's an answer. Okay, cool. Awesome. Well, listen, I want to thank our panelists. I know we didn't do a great job getting to all the questions. Emily, you picked all the right ones. I looked down the list. That was great. Thank you to our organizer, Allison. Thank you to the Fall Voice people. We will see you in D.C. in a couple weeks. And then next year, I got to show this slide. Ta-da! It's going to be in Seattle next year. Looking forward to seeing you there. Take care. Peace. Good job, everyone.
Thank you.
Bye, everyone.
Really
Bye.
great panel. Really good job, guys. Bye-bye.
Thanks.